Hi, so we've been looking at the skull, talking about the skull, and I think the obvious next step, we all know, it's got to be done, cranial nerves. Let's talk about the cranial nerves. Now, I actually taught this morning to a group of students, so this is in part a test of what I can remember. I will likely leave some stuff out. Hopefully not because I've forgotten it, but intentionally. What I really should do is work through the list of the 12 cranial nerves after introducing them and talk about the salient points of each cranial nerve with notes on how you would test the function of each cranial nerve, right? I mean, if you look in a textbook, there's tons of detail. You want detail, go to your textbooks. You can add on to that. What I want to do is to get across the important stuff, the stuff you need to know, the stuff we need to know. All right, so I'm not going to dumb it down. Some of these nerves have got a lot going on. They're very busy nerves, but let's keep it sensible. Right, what do I need? What do I need? Eye, do you know about the eye? Skull. Check out Big Head. I love these models, they're awesome. Brain. Okay, so the cranial nerves are nerves that come out of the brain and the brainstem. Right? Cranial nerves 1 and 2 are often considered direct extensions of the brain, whereas cranial nerves 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 come out of the midbrain, the pons and the medulla and the first part of the spinal cord. And they're named sequentially as we descend. And when we looked at the foramina, we saw that those cranial nerves left the cranial cavities through foramina in ever increasing numbers as we went inferiorly, right? So if we start with cranial nerve 1, which is a nice easy one. So cranial nerve 1 is here and here. We see these two what get called olfactory tracts. So these are the olfactory bulbs, and those olfactory bulbs sit in these two depressions here, and that's on top of the ethmoid bone, and you can see a lot of holes in there, right? So from those olfactory bulbs, nerves pass into the nasal cavity. Those nerves end in olfaction detectors that detect smell. The action potentials are carried up to the olfactory bulbs and back to the brain. So that's cranial nerve 1. Olfaction, smell. That's all it does. Cranial nerve 2. Now cranial nerve 2 passes to the retina in the eye. This is the optic nerve. Cranial nerve 2 carries visual information from the retina. And it's this great big nerve in here. And it passes out through the optic canal and it's quite well protected. Now the optic nerve of each eye carries visual information from the retina back towards the brain. The two optic nerves meet at the optic chiasm, which we can see on the brain here, and this chiasm is around here. So here's the pituitary gland, and the optic chiasm is just superior to the pituitary gland. At the optic chiasm, some of the nerves from the retina cross over to the other side, and some stay on the same side and then travel back to the lateral genicular nucleus through the optic tract. The nerve becomes a tract because it's within the central nervous system rather than dangling out from the central nervous system. And then from the lateral genicular nucleus, which is right on the back of the thalamus, it then passes to the visual cortex in the occipital lobes, right? There are a couple of things to consider. Damage along that pathway will have different effects upon vision. Now if you sever an optic nerve, and the optic nerve is pretty well protected, but if you sever an optic nerve, then obviously you're going to lose the visual information from the retina on one eye, so you'll have monocular blindness. But if you damage the optic chiasm, you'll see a loss a partial loss of a visual field. And of course, we've got overlapping visual fields from both of our eyes, so that can be quite difficult to detect. Something that's probably clearer to describe is when we get to the optic tract. If that gets severed on one side, then if, say, the right side of the optic tract was severed or compressed or damaged in some way by a stroke, for example, then the patient would experience a loss of the left visual field. Does that make sense? So the left visual field in my left eye and the left visual field in my right eye would be lost. So patients often walk into things because they don't see them. They can see over here, they can see over here, but this stuff they don't really notice they can't see. So if you get them to, you know, follow your eye and see how much they can see, you'll pick that up. That's bitemporal hemianopia. So if you have damage to other parts of that visual pathway, you'll get slightly different things going on. So that's a little bit outside the topic that I wanted to talk about, but watch out for that. Okay, it's tricky stuff. So that's the optic nerve. Now, cranial nerve 3, the oculomotor nerve. Oculomotor is going to innervate almost all of the extrinsic muscles of the eye, so that means the muscles that move the eyeball, and the oculomotor nerve is also going to innervate most of the muscles within the eye. Now, what muscles are there within the eye? What do you need to move within the eye? Well, you need to dilate your pupil, and you need to be able to constrict your pupil to adjust the amount of light that enters the eyeball, right? And of course, you need to change the shape of your lens so you can focus on things that are nearby and then focus on things that are at a distance, accommodation. Obviously, dilating and constricting your pupil is autonomic. It's under autonomic control. It's not something you can control. So, it must be controlled by sympathetic or parasympathetic innervation. Do you think the sympathetic branch of the autonomic nervous system causes pupillary dilation or pupillary constriction? It's pupillary dilation, rabbit in the headlights, fight or flight response, right? Sympathetic innervation causes your palpebral, your eyes to open widely, and it also causes the pupils to dilate. So that's the sympathetic nervous system. That means that the parasympathetic nervous system must innervate constrictor pupillae, the muscle that constricts the pupil, makes the pupil smaller, right? And those parasympathetic fibers also come from the oculomotor nerve. So the oculomotor nerve is going to cause pupillary constriction, and it's going to innervate most of the muscles of the eye that move the eye around. So when you shine a light in somebody's eye, that light is detected by the optic nerve, passes back to the brain, passes back to a reflex, and that then causes the parasympathetic nerves of the oculomotor nerve to cause the pupil to constrict, right? So if you shine a light in somebody's eye and their pupil doesn't constrict, then there's a problem somewhere along that pathway or within the brain. Cranial nerve 3, the oculomotor nerve, comes from the midbrain, so you might be finding signs of damage to the midbrain if somebody doesn't constrict their pupils in response to bright light. Okay, that's cranial nerve 3. There are 2 muscles and 2 nerves innervating those muscles attached to the eye, that move the eye. Those are cranial nerves 4 and 6. Let's take those 2 and then we'll talk about cranial nerve 5, right? Cranial nerve 4 is the trochlear nerve. Trochlear comes from the word meaning pulley, and the trochlear nerve innervates the superior oblique muscle. Now look, so I've removed the superior rectus muscle, and what we see here is the superior oblique muscle. And now look, the superior oblique muscle sends a tendon through this pulley, and then it passes over the top of the eyeball. So what the superior oblique muscle does is it rotates the eye that way, in torsion. Have you ever noticed that your eyeballs rotate? No? Go stand in the mirror, have a look at your eyes, tilt your head from side to side, and you'll see that your eyes stay level while your head tilts. It's cool. If you tilt your head too far, the world starts to tilt as well. But the superior oblique muscle, and its friend, the inferior oblique muscle, will rotate the eye with intorsion and extorsion to keep the world level as you tilt your head. Now, back to the cranial nerves. So because this muscle passes through a pulley, the nerve that innervates it is the trochlear nerve, which is cranial nerve 4. Cranial nerve 6 is the abducens nerve, abducens to abduct. So that innervates the lateral rectus muscle, which abducts, which abducts your gaze, right? So lateral rectus pulls your gaze laterally. So abducens nerve innervates lateral rectus, causes abduction of your gaze. And that's cranial nerve 6. Now, the movements of the muscles of the eye are described well, but when you're examining these cranial nerves, the movements that you use to examine these cranial nerves are not the same as the primary movements of these muscles. Because, so the pupil is pointing this way, but the orbit is actually pointing that way. The orbit, the direction of the orbit and the direction that the muscles are aligned in are not the same as the direction of gaze. This means that while a muscle might have one action or another action, many of their actions can be duplicated by other muscles working in pairs, for example. So if you want to test cranial nerve 3, well, you can flash a light in somebody's eyes and you can see if most of the muscles of the eye are working by the fact that they're looking around normally. If you want to test lateral rectus, then you can ask them to look laterally, so you're testing the abducens nerve. But if you want to test the superior oblique muscle, if you ask them to look medially, then you isolate that muscle. At that point, once they're looking medially, there is no other muscle that can allow them to look inferiorly except for the superior oblique muscle. So the eye is drawn in and then it gets pulled this way around. Trust me. So you ask the patient to look inferiorly to test the superior oblique muscle, all right? So the movements you use in clinically testing these muscles and these cranial nerves are not the same as the primary actions of these muscles because they compensate for one another. It's a common source of confusion. So that's cranial nerves 1, 2, 3, 4, 6. I'm going to go back to cranial nerve 5. Cranial nerve 5 is the trigeminal nerve. It's a big nerve, it's a very big nerve. It's actually quite a landmark because it's such a big nerve and it comes from the pons. So here's the medulla oblongata, here's the pons, and this great big nerve here that's appearing from the pons, that's cranial nerve 5, this guy up here. It's a bit of a landmark if you're actually looking at somebody's brain. Now, cranial nerve 5 is a very big nerve because it's the major sensory nerve of the face. The face is very sensitive. Some areas are very, very sensitive, right? Like lips and what have you. So there are an awful lot of neurons carrying sensory information from the face back to the brain. So the trigeminal nerve is large. I can show you how large on my friend Big Head. Here's Big Head. Here is the trigeminal nerve here. And this is the trigeminal ganglion, and you can see how it splits into 3 large branches. And these 3 branches are the ophthalmic branch, the maxillary branch, and the mandibular branch. And their names give you a clue as to where they go and what they do. And they pass through the superior orbital fissure, foramen rotundum, and foramen ovale down here. So it's a big nerve. He's good, isn't he? Whoa! So the ophthalmic branch passes to sensory structures in the eye and is sensory to areas of the face superior to the eye and the scalp. The maxillary branch pops out here and is sensory to the maxillary region and the upper teeth, and the mandibular branch is sensory to the mandibular region, the lower jaw, the lower teeth, that sort of thing. It's also carrying general sensory information from the tongue, from the oral cavity, from the nasal cavity, stuff like that. So it's got a big sensory job to do. And the anterior parts of the face, not the pharynx as such. It also has a motor component, and the motor component is in the mandibular branch of the trigeminal nerve, and that passes to the muscles of mastication, masseter, temporalis and the pterygoids. It does innervate a few other muscles as well, but have a look in a textbook for that. We're not going to talk about those. It's motor to the muscles of mastication. Obviously you can test the function of the trigeminal nerve by testing sensory things, and in different regions. You can't really test you can test the muscles of mastication, but they're such powerful muscles that if you bite on one, if you just use the muscles on one side, you still bite, you still generate a lot of force and so on. Anyway, right, okay. So that's cranial nerve 5. We've already done cranial nerve 6. Now cranial nerve 7, which is the facial nerve. And if the trigeminal nerve, cranial nerve 5, is the major sensory nerve of the face, cranial nerve 7, the facial nerve, is a very busy nerve. And one of its jobs is it's motor to all of the muscles of facial expression. So all of these muscles that I'm moving in my face to talk and move my lips and my eyes and that sort of around my eyes and what have you, the muscles of facial expression are innervated by the facial nerve. And that branch pops out beside the ear through the stylomastoid foramen and passes into the parotid gland, does not innervate the parotid gland, splits into 5 branches in the parotid gland: temporal, zygomatic, buccal, marginal mandibular and cervical down to the neck, and passes to the muscles of facial expression. So you can test that part of the facial nerve by getting patients to blow out their cheeks and then seeing if they can hold their lips together while you push on their cheeks. If they can't, then they have a weakness there. But the facial nerve has a couple of other jobs as well. The facial nerve will also pass to the lacrimal glands and cause the lacrimal glands to secrete tears, which is happening all day long, to keep your eyes moist. If they dry out, it hurts. They also innervate the nasal mucosa. The mucus secreting cells within the nasal cavity secrete mucus to make snot. This is all parasympathetic innervation, by the way. Parasympathetic. And the facial nerve has a very famous branch, the chorda tympani, which drops out of a crack just anterior to the other branch and runs down to get underneath the tongue. So the chorda tympani passes down, joins with the lingual nerve and just follows it down to get under the tongue. And the facial nerve will carry special sensory information from the anterior 2/3 of the tongue. By that I mean taste, and will innervate the 2 salivary glands on either side down here, the sublingual and submandibular salivary glands. So the facial nerve is the weepy, snotty, dribbly nerve of the face, but it doesn't innervate the parotid gland. Is there anything else that it does? That's cranial nerve 7. Cranial nerve 8. Here's cranial nerve 8 here. Passes to the inner ear, and it passes to the semicircular canals and the vestibular apparatus, and it passes to the cochlea. Ear. So this is the vestibulocochlear nerve, and it innervates those things. So it's a sensory nerve. So that's easy, right? Cranial nerve 8. Cranial nerve 9 is the glossopharyngeal nerve. Glossopharyngeal. Glossus, tongue, pharyngeal, pharynx, right? So what does the glossopharyngeal nerve do? So cranial nerve 9, the glossopharyngeal nerve, has a number of jobs. It carries general sensory information from the posterior part of the tongue. It also carries special sensory information from the posterior part of the tongue, i.e. taste. Hence, that's the glosso part. Very importantly, it carries sensory information from the chemoreceptors and baroreceptors that are found in the carotid sinus. What does that mean? So here's the common carotid artery here, and it's bifurcating there. It's splitting into the internal and external carotid arteries, right? And in here we have a whole bunch of receptors measuring things associated with blood pressure and blood composition and stuff like that. And the glossopharyngeal nerve carries all that information back up to the brain. So the brain uses all this information to manage your rate of respiration, how deeply you breathe, and to manage your heart rate and how forcefully your heart contracts and things like that, right? So this is really old stuff. So the glossopharyngeal nerve is absolutely crucial to these very basic roles of homeostasis. It also has a little motor component which I even hesitate mentioning, but innervates stylopharyngeus, so a muscle passing from the styloid process to the pharynx, so you can lift the pharynx when you're swallowing. And it's sensory, carries general sensory information from the upper parts of the pharynx and the posterior parts of the mouth, right? So it's involved in the gag reflex. When an unexpected object or something too large hits the back of the throat, then the glossopharyngeal nerve is the sensory limb of a reflex that then causes you to contract the muscles of the pharynx to try to expel the object. That's the gag reflex. Those muscles are innervated by the vagus nerve, which is next, which causes contraction. The glossopharyngeal nerve also carries sensory information from the middle ear, but its other big job is here's the parotid gland, parotid paraotic, beside the ear. So the glossopharyngeal nerve sends parasympathetic fibers to innervate the parotid gland and cause it to secrete saliva. Okay, how are we doing? So that's up to cranial nerve 9. Now cranial nerve 10, the vagus nerve, comes up time and time again. The vagus nerve is very big, very busy. Vagus means wandering, it is the wandering nerve. It supplies parasympathetic innervation to all structures that need it, pretty much in thorax and the abdomen. Along the GI tract about as far as the splenic flexure of the large colon. So the vagus nerve is a busy boy. We also see it innervating the intrinsic muscles of the larynx through the recurrent laryngeal nerve. We see it innervating other parts of the larynx through the superior laryngeal nerves and its branches, so it innervates structures of the larynx. It innervates muscles of the pharynx, it innervates muscles of the palate. Interestingly, it also innervates a small region of the external ear. And you might come across people who, when they scratch their external ear, it causes them to cough or something similar, because they're stimulating the vagus nerve, and all these things are linked. So that's a really brief summary of what the vagus nerve does, but it's very busy. It does a lot of things. Cranial nerve 11 is the spinal accessory nerve, and the spinal accessory nerve is fairly straightforward in that it innervates the sternocleidomastoid muscles, and it innervates trapezius. So you could ask somebody to shrug their shoulders against resistance. So the fibers of the accessory nerve will innervate trapezius. If the accessory nerve is damaged, they won't be able to shrug their shoulder. In fact, patients with damage to the accessory nerve often complain first of being unable to scratch their heads, brush their hair, because the trapezius muscle rotates the scapula, lifting up, elevating or changing the angle of the glenoid fossa, meaning you can lift your arm up above horizontal and get it above your head. So if trapezius doesn't work, you can only get your arm to about there. Right? So the accessory nerve innervates trapezius and sternocleidomastoid. You could also, of course, get the person to rotate their head against resistance and test the strength of that. Now the accessory nerve, so look at this. This is a cutaway of, here's the brain. Look, there's the first cranial nerve. There's the optic chiasm up there. There's the pons. There's the medulla oblongata, and it continues as the spinal cord. So you can see all the cranial nerves coming off here. And this is a really nice model. Everything's really labelled, but it's not, not great for a video. But down here, there's cranial nerve 12, which we'll get to in a moment. But can you see here? Arises from the medulla oblongata, but it also has rootlets arising from the spinal cord, which is why it gets called the spinal accessory nerve. And these rootlets come together to form the accessory nerve, which goes up and this is going up through the foramen magnum, the big hole at the bottom of the skull, and then it's leaving through the jugular foramen down here. So this is probably the nicest way I've seen this represented. So there's the cranial nerve 11, the spinal accessory nerve forming, going up into the cranial cavity and coming out through the jugular foramen. It's rather neat and pretty, and is a hell of a dissection to do so. Finally, cranial nerve 12 is the hypoglossal nerve. Hypo below, glossus tongue. So this is a nerve that is going to go below the tongue. And what's it going to do there? The hypoglossal nerve is going to innervate all of the intrinsic muscles of the tongue and most of the extrinsic muscles of the tongue. The intrinsic muscles of the tongue change its shape, and the tongue's quite weird because many of the muscles don't attach to anything at one end, right? They just pull and change the shape of the tongue, and the extrinsic muscles anchor the tongue within the mouth and move it around in the mouth. So to test the hypoglossal nerves, you just ask the patient to project their tongue anteriorly, and because the hypoglossal nerve causes the muscles to contract on both sides and squeeze the tongue and make it longer, if the hypoglossal nerve doesn't work on one side, it'll be unable to do that, so the tongue will deviate to the weak side. The tongue will deviate to the side of the damaged hypoglossal nerve, if it's the hypoglossal nerve that's damaged and not part of the brain. Okay, that's it. That wasn't so bad, was it? And that's it, the 12 cranial nerves. Obviously there's a lot of detail in the cranial nerves, but they're very, very important. Head injuries are life-threatening. Head injuries cause big problems. If you can confidently examine the function of all the cranial nerves in somebody, then you can get a lot of information about what's going on inside their head. If you can remember what cranial nerve does what and how you test it, it's really good information. So spend some time on it. So how did I do? Did I miss anything out? Did I get anything wrong? Leave a note in the comments if there's anything I've omitted or made up or not being clear about. I've tried to be succinct. I do make occasional slips of the tongue, so watch out for those. You'll also see in textbooks there are slips of the textbook, and you'll see errors elsewhere. Don't trust what I say, don't trust what the textbooks say, don't trust what the models say. Bring all that information together and work it out for yourself, because we all make errors. Trust multiple sources, all right? Okay.